My name is Beau Hawkins. I am an interventional cardiologist from the University of Oklahoma Health Sciences Center in Oklahoma City, Oklahoma. And I'm pleased today to present to you Module 3 of the SCAI-PAD Diagnosis and Treatment Toolkit. This was developed in collaboration with one of my colleagues, Dr. Sahil Parikh, and we greatly appreciate his involvement with this project. I hope to, over the next 25 to 30 minutes or so, review the pertinent aspects of medical therapy for peripheral artery disease. Now, as many of you all know in the audience, peripheral artery disease is an underdiagnosed and undertreated entity, and this is some data that actually reflects that. It is a large observational data set published several years back looking at the degrees in which medical therapy was applied to patients with peripheral artery disease. And this graphical display here on the right actually shows us a couple of things. Number one, if you look at patients that are diagnosed with peripheral artery disease, you find that for whatever reason, and it's probably a lot of different reasons, clinicians taking care of these patients are not that commonly prescribing aspirin for these patients. And interestingly, when you compare that to patients that have other forms of cardiovascular disease, such as coronary disease, in this example, you find that aspirin use is actually much higher in the coronary population than it is in the PAD population alone. So this essentially identifies that there's a gap that exists in how we take care of patients with peripheral artery disease. For whatever reason, our patients with peripheral artery disease are being undertreated with medical therapy. Now, when we talk about medical therapy for peripheral artery disease, we imply a lot of things. So this would be kind of a wheel diagram looking at all of the important aspects of guideline-directed medical therapy in taking care of patients with PAD. So this includes antiplatelets and antithrombotic agents. It includes the use of cholesterol-lowering agents such as statins. It includes nicotine cessation and exercise programs, and then it also importantly involves treatment of relevant comorbidities such as hypertension and diabetes. Let's start with antiplatelets. We all know that antiplatelets are an important form of therapy for all patients with cardiovascular disease. In particular, we know from the coronary and cerebrovascular literature that aspirin is an important medicine that lowers rates of heart attack, stroke, and all-cause cardiovascular death. However, in light of that, it's also fairly well established that the benefits of antiplatelet therapy in patients with PAD are less well established. So what our current guidelines reflect, and this is the most recent ACC-AHA iteration of our guidelines, would be that aspirin or clopidogrel is a class 1 level of evidence A recommendations for all symptomatic patients with PAD. So these are patients that have some form of leg symptoms, or if they are in the more advanced forms of the stages of the disease, such as those with breast pain or tissue loss, an antiplatelet agent is a class 1 recommendations. You see just below that actually if you're asymptomatic, meaning patients that are found to have peripheral artery disease but aren't necessarily having any symptoms, the recommendation for antiplatelet use is less strong. It's only a 2A, and we'll talk about some of the reasons why here in a second. So what about risk reduction with aspirin in the PAD population? This is one of the larger data sets that we have. It's a meta-analysis looking at 18 randomized trials involving over 5,000 patients, all of whom had peripheral artery disease. And essentially what was found when you compare aspirin to placebo therapy in this group is that you find there's a non-significant reduction in the composite endpoint of mortality, heart attack, or stroke. That is a non-significant p-value, though there is a trend towards benefit in the aspirin therapy group. You also see that there's not any significant differences in mortality or MI rates between groups. However, importantly, there was a reduction in ischemic stroke rates with aspirin monotherapy in these patients enrolled in these trials. So on the basis of this data, we would say that aspirin alone compared to placebo therapy in our patients with PAD is not going to significantly reduce a composite endpoint of heart attack, stroke, or death. However, it does seem to have benefits in terms of the single endpoint of ischemic stroke reduction. What about clopidogrel versus aspirin? Again, an important question and an important clinical situation that we find ourselves involved with when we're taking care of our patients with PAD. This is, again, a data set that was derived from the Capri trial, which was a landmark study published now 20 years ago or so. And it attempted to identify whether or not aspirin or clopidogrel was most efficacious in reducing cardiovascular events in your patients with peripheral artery disease. Here in this subset analysis, you see that they found analyzed almost 6,000 patients in each group and compared the benefits of aspirin versus clopidogrel. In this study, they were able to determine that clopidogrel was more efficacious than aspirin in lowering your event rates. And so on the basis of this data, it would seem that when you're applying therapies, antiplatelet therapies to your PAD patients, clopidogrel is probably going to be a little bit more effective than aspirin alone. What about other therapies? Again, these are some of the less commonly used agents to treat peripheral artery disease, but they're important to understand the data behind nonetheless. This is a randomized trial that was published quite some time ago looking at whether or not cilostazol was more effective than placebo in improving symptoms of claudication in patients with peripheral artery disease. And the take-home message from this is that cilostazol was actually quite effective in improving walking distance in your claudicants, and this is compared to either placebo or the other agent listed here, which is no longer in use. So on the basis of this study, cilostazol is an important medicine to remember for your patients that are having lifestyle limiting symptoms when they walk. It can improve walking distance. It improves the symptoms that patients have when they walk, and it should be applied in the appropriate patients with PAD. And this also makes it into our guidelines currently. So cilostazol is an important agent for your claudicants. What about dual antiplatelet therapy? Again, a good question because a lot of our patients with PAD are going to have concurrent coronary artery disease, and a lot of these patients may have indications to be on dual antiplatelet therapy already. This is a sub-study of the Charisma trial. It looked at 3,000 or roughly 3,100 patients, the majority of which had symptomatic peripheral artery disease. And they compared the use of dual antiplatelet therapy consisting of both aspirin and clopidogrel to aspirin monotherapy alone. And they looked at a standard composite endpoint of death, myocardial infarction, or stroke. You can see here that the composite endpoint was not reduced relative to aspirin alone in terms of the composite endpoint of death, MI, or stroke. You can see that rates of death were in favor of the dual antiplatelet therapy, and that was significant. Stroke rates were not different between the two. Major bleeding rates were also similar between the groups. However, you do see that there was more minor bleeding in the dual antiplatelet therapy group, which does make sense clinically. I think we see this in our own practice. So on the basis of this, there would not be, on the basis of this data set, there would not be strong evidence saying that dual antiplatelet therapy is more efficacious than aspirin monotherapy alone. You do have a slight reduction in your MI risk over time. But again, remember that that seems to be counterbalanced by a higher bleeding event rate as well. So this is what the dual antiplatelet therapy data would look like relative to PAD. Now, what about some of the newer antiplatelets? So this has been, these have been popular agents in cardiovascular medicine over the past few years. And we now have a lot of different antiplatelets we can apply to our patients with cardiovascular disease. This is a very important trial, the Euclid trial. Published just last year in the New England Journal of Medicine. It examined roughly 14,000 patients with symptomatic PAD, and these patients were randomized to either ticagrelor or clopidogrel. So it's important to understand that the comparator here was clopidogrel and not aspirin. So this is a trial trying to determine if more robust platelet inhibition might be more effective in treating your patients with PAD and lowering risk. The primary endpoint here was cardiovascular death, myocardial infarction, or stroke. Mean follow-up was 30 months. And overall, the take-home message of this is that there were similar rates of endpoints in the ticagrelor and clopidogrel groups. So they appeared to be equally efficacious. Ticagrelor did not outperform clopidogrel on the basis of this trial. Another study was called the Pegasus study, and this was a PAD sub-study specifically trying to understand what the impact of dual antiplatelet therapy in a PAD subset of patients was compared to aspirin monotherapy. So here, as opposed to the prior trial, we're looking at dual antiplatelet therapy with ticagrelor and aspirin and comparing that to aspirin alone. The sub-study included 1,143 patients with peripheral artery disease. This was approximately 5% of the total Pegasus cohort, so a really pretty small sample size from that overall trial result. And this was a post-hoc analysis as well. Essentially, what was found was that at follow-up, which was about 3 years, there was a significant event reduction in the ticagrelor arm. You can see here the absolute risk reduction was 4.1%. That corresponds to a number needed to treat of approximately 25. So there was benefit in this study with the use of dual antiplatelet therapy relative to aspirin alone in reducing endpoints in patients with peripheral artery disease. The endpoint here I didn't mention previously was the standard composite of death, MI, or stroke. Again, so important data suggests that there may be benefit now utilizing a newer antiplatelet agent in conjunction with aspirin to lower cardiovascular risk in patients with peripheral artery disease. Another take-home interesting message of this same sub-study was the rates of adverse limb events, okay? And what was probably not anticipated here is that ticagrelor use was actually associated with lower rates of both acute limb ischemia and total rates of peripheral revascularization. So that's kind of an interesting slant on this same study. It appears that dual antiplatelet therapy was beneficial in reducing your limb events, not just cardiovascular risk overall. So again, kind of an important finding, something that we had not necessarily seen before, and something that may be important for our patients. Interestingly, we would also anticipate that dual antiplatelet therapy might be associated with higher rates of bleeding. That was not demonstrated in this analysis. Both the 60 milligram BID doses as well as the 90 milligram BID doses did seem to have similar bleeding rates relative to the control arm. Okay, moving on, let's talk about the TIMI 50 study. This looked at vorapaxar, and this analysis looked at almost 6,000 patients with peripheral artery disease. The analysis was trying to determine if vorapaxar compared to placebo on a background of standard medical therapy for patients with peripheral artery disease was successful in reducing any of the important cardiovascular endpoints. Overall, what was identified in this study was two things. Number one, the use of vorapaxar, as we would anticipate, was associated with higher rates of bleeding. However, vorapaxar was also associated with reductions in the need for revascularization. You can see the numbers here. There was almost a 4% absolute risk reduction in terms of the need of having peripheral revascularization during a mean follow-up of 2.5 years. You can see also above these numbers is that when we looked at mortality or composites of death, MI, or stroke, those rates, those adverse cardiovascular event rates, were similar between groups. So again here, no benefit in terms of cardiovascular risk reduction, though the use of vorapaxar, at least based on this analysis, was associated with reduced need for peripheral revascularization during the study follow-up period. So important for our patients, important data to have. More recently, the results of the COMPASS trial have been published, and again, I would say that this has already been perceived as a landmark study in cardiovascular medicine. This was a large study looking at 7,470 patients with either peripheral artery disease involving the leg or with carotid artery disease. Patients in this study were randomized to either aspirin, rivaroxaban, or combination therapy with the two. The one point I would make about this is that the rivaroxaban dosing was low here, so it was 2.5 milligrams twice a day as opposed to the larger doses that you would use for other indications for this therapy. The primary endpoint was the standard of death, myocardial infarction, or stroke, and they also attempted to look at limb events, and major adverse limb events in this study was defined as acute limb ischemia, critical limb ischemia, or amputation. What was overall determined on follow-up was that the combination therapy with aspirin and rivaroxaban seemed to outperform the other two groups, so it was more effective in lowering the primary endpoint then was aspirin monotherapy or rivaroxaban monotherapy, again with a significant risk reduction in death, MI, or stroke. Additionally, as we talked about previously in the other studies, there was a reduction in acute limb ischemia and overall major adverse limb events in the combination therapy group with aspirin and rivaroxaban compared to the comparator arms. So again, these not only did this combination therapy utilizing an anticoagulant result in lower rates of cardiovascular events, it also improved limb outcomes, which is also very important for the patients that we take care of. What about statins? Just to change gear now and get off of the antithrombotic agents. Statins, as we know, have been great medicines in all aspects of cardiovascular medicine, and equally so in patients with peripheral artery disease. So statins should be prescribed to all of your patients that have peripheral artery disease. This is a class 1 level of evidence A recommendation. Statins also are associated with improved walking distance and physical function in your claudicants. Statin use is also associated with improved patency following lower extremity revascularization period. Now, that may not be a causal effect, but nonetheless, if you have patients on statins, their overall results following revascularization procedures does seem to be improved. We also know that statins improve limb salvage rates, and we also know that statins reduce the rates of stroke, myocardial infarction, and death in all of your patients with peripheral artery disease. So these are very important first-line medications for patients that you take care of daily. What about smoking cessation? So again, another important aspect of medical therapy for PAD. I think it's easy sometimes for us as clinicians to kind of blow off the importance of talking to our patients about smoking cessation or offering them some help in terms of cessation, but nonetheless, it's important to know that there is data that suggests that if you're active with your patients in this regard and you can get them into smoking cessation programs, that these programs do appear to be efficacious. This is one study that looked at patients who were randomized, and these are all patients that had peripheral artery disease at baseline. These patients were randomized to a usual nicotine cessation program, which is probably what we most of the time do in our clinic, where we talk to patients about smoking, tell them that it's bad for their health and they need to quit. That strategy was compared to referring these patients to an intensive program where they received counseling and education at regular intervals, and they were offered pharmacologic methods to help with their cessation. And essentially the take-home message of this analysis and this study was that if you get them into a more rigorous cessation program, you're actually going to improve the rates of complete abstinence over time. So again, I would urge all of you in taking care of these patients that if you have these types of resources available for your patients, you should go beyond just talking to them briefly or casually in clinic about stopping. Try to get them into these programs, because there is some compelling data suggesting that these programs are effective. We also know that medications, there's lots of different pharmacotherapies out there that can now be utilized to help patients quit smoking. This is some data looking at varenicline. We know that this is probably the most commonly used agent to help with cessation. And again, it has sustained results both out to midterm, half a year, and also results that are even longer now, out to 1 year, showing that you have sustained reductions in nicotine use when you apply these medical therapies to patients that have continually smoked in the past. So these are effective medicines. They should be utilized when at all possible. They seem to be more effective than usual care in trying to get your patients to quit smoking. What about exercise? Exercise, the importance of this cannot be underscored enough. So all of your claudicants should have discussions daily with, or not daily, at every clinical visit regarding the importance of exercise and physical activity in helping their symptoms. There are essentially two types of exercise that can be utilized. These include supervised exercise as well as home-based programs. And some of these programs and the availability of these programs is going to change over the upcoming years, mainly due to reimbursement considerations. But nonetheless, I think that the important message for us is that both of these types of programs can be effective, and randomized data does support the efficacy of both types of these programs. This is just some of the data depicted here on the right that looks at changes in treadmill walking distance. You can see that when you apply an exercise training program to your patients with claudication, you're able to improve the severity of their symptoms, and you're also able to allow them to walk longer and have less or have greater pain-free walking distance when you use these more rigorous programs to try to help out their symptoms. So don't stop with just usual care, counseling, and clinic. If you have these programs available to you, patients should be instructed on these because it does impact their quality of life and allow them to function on a more normal basis. Now, a couple of comments about structured exercise programs. This is from the most recent guideline iteration published last year, and it kind of compares what a home-based exercise program would look like relative to a supervised exercise program. I won't go through all the details here, but just understand that the supervised exercise programs are the ones that are going to take place in an outpatient clinical facility or in the hospital. And generally speaking, these types of programs include multiple sessions that occur over the course of a week, and most of these sessions are going to be at least 30 to 45 minutes in duration. They include provider supervision of their exercise program, and it's designed to kind of be a more intensive, more supervised exercise program relative to the home-based programs which you see described below here. Importantly, at least within the United States as of this year, we now have approval for patients with claudication to receive supervised exercise training programs. These are some of the specifics of what this type of program would look like. Again, it's going to be a 30 to 60-minute session in an outpatient hospital or physician office setting. CMS has agreed to cover a total of 36 sessions occurring over a 12-week period. These sessions will have a supervisor or qualified personnel present to deal and troubleshoot with any issues that may arise. And then exercise prescriptions must be prescribed following a face-to-face meeting between the patient and a provider. And this also must include counseling on cardiovascular disease prevention. So these are relatively straightforward things to meet. And I think all of us that take care of a lot of patients with peripheral artery disease are excited about this coverage decision, because I think we realize that this has been a valuable therapy for our patients that we've not always had available in the recent past. Couple of closing remarks talking about the role of exercise versus revascularization. This is data from the ERASE trial, again, a large trial published just a couple of years ago that looked at the impact of revascularization on top of supervised exercise and wanted to understand if this type of combination therapy that included revascularization was better than just supervised exercise alone. Remember that these are all claudicants at baseline, and all of these patients had either aortoiliac or femoral popliteal disease. And what was determined during the 12-month follow-up is that the revascularization plus exercise arm outperformed the supervised exercise arm alone. And this is based on walking distance. Here you can see the 12-month results. Walking distance was significantly longer in the endovascular revascularization arm compared to supervised exercise. And then if you looked at pain-free walking distance, you can also see that this also favored the revascularization arm. So again, this trial will suggest that when you add on a background of medical therapy and exercise, you add revascularization as a therapy for your patients with peripheral artery disease, it does seem that they have more benefit relative to the standard measures alone. Another trial that's also important and would be considered a landmark trial is the CLEVER trial. Again, this was patients with just aortoiliac disease, and they compared three strategies for taking care of these patients. One was just medical therapy. Two was the medical therapy with supervised exercise, and then the third was angioplasty and stenting arm. And I think the take-home message, this is 18-month follow-up data. There was sustained improvement with either stenting or exercise relative to medical therapy alone. So this would suggest that we have at least complementary therapies when we talk about taking care of patients with claudication, and that, you know, revascularization or exercise programs seem to be better than just offering medical therapy alone. To summarize, we close by saying that antiplatelets, statins, nicotine cessation, and exercise are recommended as first-line therapies for the treatment of peripheral artery disease. We know that clopidogrel monotherapy is more effective than aspirin at reducing composite adverse cardiovascular events in your patients with PAD. Dual antiplatelet therapy utilizing either clopidogrel or ticagrelor reduces MACE compared to, reduces some cardiovascular endpoints relative to aspirin alone. Dual antiplatelet therapy with ticagrelor is associated with reductions in adverse limb events. We talked about that data. Vorapaxar use is associated with reduced rates of peripheral revascularization. Rivaroxaban, a newer anticoagulant plus aspirin, reduces both major adverse cardiovascular events and major adverse limb events in your patients with peripheral artery disease. And then finally, exercise therapy with or without revascularization improves functional outcomes in your claudicants. Thank you.